Good afternoon again. So this is the 1 o'clock meeting on the HOT team in action, managing complex TAVR scenarios. I'm Alan Young from Stanford and Jin Kim together with me. We have total of 6 talks, and we have 3 surgical discussion, actually 5 talks, 3 surgeons presenting and 2 cardiologists presenting, and we have a Q&A and interactive section at the end. So without further ado, we have the panelists on. I think we are here, and then we invite Dr. Kazuo Shimamura from the University of Osaka in Japan to talk about prevention and management of annular rupture in TAVR.
So thank you very much. It's my great pleasure to have the opportunity to present my case here. This is my disclosures. So this is evolution of TAVR SAVR in Japan. So we start our TAVR program in 2013, and last year, the total number in the country exceeds 17,000 cases per year, and it's far above the number of surgical VALVES. And we look at the patient's background of the TAVR cases. Still, the age is around 84 years, so it's quite high age, and the 1/4 of the patient has an NYHA 3 or 4 out of failure, so they are very severely has a severe decreased health function. And from 2021, the renal dialysis patients is also approved for the treatment, so around 8% of patients have the renal dialysis. And we look at the transition of the surgical risk. We still have a very conservative, and we don't do lots of what's called low-risk patients. So when we look at last year, the SDS score less than 4% is just around 70%, and the majority of the case has a high surgical risk. So in Japan, we still have a relatively conservative indication for the TAVR. These are the expansion of the TAVR indication in Japan. Again, we have a lot, currently we have 4 different devices from 3 companies. And when we look at the results, the all-cause deaths within 30 days is around 1.2%. So we could say that the result is quite good. But we still have some open conversion. It's just 0.3%, but we do have. And when we look at the annular rupture, it's 0.2%, and the annual case is around 30 in the country. But yesterday, we do see a very excellent case from Assam Medical Center. They showed the excellent result in a very, very highly calcified annulus. I would like to congratulate to the Assam team on the outstanding case. But again, let's come back to the real world. We are not always can do like Assam Medical Center. And this is one of the representative case. So this is an 86 years old female with a very severe AS and with the end-stage chronic kidney disease. And as typically in the high-age Asian patient, she has a very tiny aortic root with an annular size of around 21 and very small sinus of Valsalva around 24 to 26 millimeter. So for this case, we selected the Evolut Pro Plus 26. And because of the highly calcified valve, there is a significant PVL after the implantation. So we are forced to do a post-dilatation with a gradual size of the balloon. Still, but you can imagine what happened. So we don't make our 100% oversize, but we encounter this kind of annular rupture. This is the post-operative CT image. Actually, this is not an annular rupture, but as is often seen, it is a rupture of the sinus of Valsalva with the sticky calcification. And what would be the clinical cause of the case? Because she is a very high-age case with chronic kidney disease, so we cannot rush into what's called open repair. So we did our ECMO support and pericardial drainage. And after giving a protamine and with a manual compression with the partial sternotomy, we can achieve the hemostasis. And during this manual compression, we talked to the family whether we have the option to do our radical open repair, but the patient, the family doesn't want to be treated in the conversion. And luckily, this patient does not need for full open repair, and we just keep the ECMO for the decompression. 3 days, but she had a very good course afterwards and discharged to the rehabilitation on 30 days POD. And she is still arrived and coming to showing up herself to our outpatient clinic at 5 years. So this is one of the case. So what would be the risk factor for annular rupture? So there is anatomical factor with a severe calcification, small annulus or root, aortic root, or bicuspid valve is also one of the risk factor. And for the technical factor, balance expandable valve is associated higher incidence of annulus rupture compared to the self-expandable valve. Of course, so oversizing too much is the risk. So when you look at this case, as again, it's a typical Asian patient. She has a severe calcification with a small annulus and narrow aortic root and end up in the basal rupture. This is our series. We had 8 cases of annulus rupture. Mainly this is in our very early experience, and the percentage is 0.3% in our series. And interestingly, we call it annular rupture, but the 75% is not the annular, but it's superannular, so the rupture of the sinus-valsalva. And as a surgeon, what we can do for this kind of complication? And we propose a 3-step management strategy for annular rupture. One, because we have our instinct to want to open it and do our root repair. But wait a moment, first we have to do immediate hemodynamic stabilization and then move to the manual compression to discuss about the radical repair and move to the step 3 to select go or no go decision. So in the step 1, the first one we have to do is the immediate hemodynamic stabilization. So we have to recognize what is going on by the contrast extravasation or pericardial effusion or hypotension. And we have to reverse the anticoagulation to achieve the hemostasis. And of course, we have to give the volumes, and sometimes we need ECMO to support the hemodynamics. And the absolutely immediate pericardial drainage is mandatory. And maybe before rushing into the root repair, one important step is to do a manual external compression. And we can do with even in the partial sternotomy. And this often works well as a radical procedure, even, especially for the patients who have no option for open repair. So the definition of the open repair, go or no go, would be decided with the amount of bleeding or the hemodynamic instability and structure extension, and whether she is or he is a surgical candidate or not. And the mostly important is the consent for the surgery. Of course, we have to ask for the family whether we have the option to go for open or not. This is our institutional outcome. So the 5 cases out of 8 we can save just with the pericardial drainage, because as long as we take care about the oversizing, we don't see a huge rupture, but usually it's a very tiny crack. So only with the pericardial drainage with the protamine could work well. And 2 cases required manual compression, but again, this was very effective to save the patient. We just only have 1 case to go for the radical procedure. So thank you very much, ladies and gentlemen. This is a take-home message. Highly calcified burden and narrow aortic root are major risk factors, and these are the patients we are treating nowadays. And aggressive bone expansion increases rupture risk, and control before conversion. So don't follow a surgeon's instinct. Convert only when compression fails. The go and no-go decision must be structured and patient-centered. Thank you very much.
Thank you very much for excellent lecture, Dr. Shimamura. So discussion will be continued after 5 presentations. The next speaker is Dr. Daisuke Hachinohe from Sapporo Cardiovascular Clinic in Japan. He's going to talk about his experience with BASILICA treatment.
Okay, good afternoon, ladies and gentlemen. Thank you for having me, and we're happy to come back here again. So at this session, I'd like to talk about the BASILICA procedure, which is very nice technique, but it has light and shadow. So, you know, TAVR in SAV and TAVR in TAV, there are some concerns. One of critical issue is coronary obstruction. So coronary risk plane and valve to STJ or aorta and coronary is one of the predictors of occlusion. So in addition, externally mounted leaflet is another strong predictor. So this is male in his 80s who has a history of surgical AVR using soaring crown 23 millimeter 6 years ago at another hospital. And coronary height is around 4. And valve TSTJ at left side is around 3. So we decided to do BASILICA in this patient. And shorten the JR4 catheter was into LV and 18-inch guide wire into LV to stabilize the guiding catheter. And one snare was situated at LVOT. And this is also shortened 8 French L2 onto the aortic valve. And the 5 French IM catheter was inserted as a child catheter. And fine cross GT and the nuded L-stat guide wires located at the aortic valve. And here is side view. So this is a CT scan. So in advance, we usually make this side view and swing to MFS view to check the axis. So actually, we can see a left coronary here. So we can adjust the system toward the base of the leaflet and the center of the leaflet. So not commissure side, just immediately before, immediately in front of the left coronary artery. So we have to adjust the guiding catheter using this MFS view. Of course, the side view and straight view is also important, but this MFS view is very easy to adjust the guiding catheter. So like this. So we usually use this side view and MFS view. And leaflet traversal with, usually we use 50 watt or 70 watt cut function. And the cross start into one snare, and guide wire is snared by this AR2 catheter and invaginated into the LVOT catheter. And balloon dilatation using 5.0 balloon. This is balloon augmented BASILICA. So we inflate the leaflet. And the Evolut was implanted as usual. So this is a way of the BASILICA. So, but shadow is here. So what is happening here? So during traversal at the right corner leaflet, so I start. So here is right side. So I start wires into the LVOT, but you can see after wire went into septal myocardium. So can you see this? This is the interceptor myocardium. So ulcer was into here to here. So this is one thing. And what do you think is happening? So this is another patient. So the guiding catheter is here, and during traversal, so we can see some bubble in area left atrium. So guide wire is into the left atrium through aortic cardium. And ideally, the traversal wire should come from the external side to the internal side. So, however, the guiding system does not always allow precise control of the wire trajectory, and the wire may occasionally tend to move outward like this. So, especially in the case of patient has very large aorta or horizontal aorta, it is sometimes difficult to control the guiding system. So when the guide were deviated from intended trajectory, so it may go into left atrium or traverse mitral valve on the left side, and while on the right side, it may pass through the interventricular septum myocardium. So this is another case, the history of surgical AVR with 19 millimeter mitral flow. So she has a big ascending aorta of 56 millimeter. So she was referred from another hospital to do a BASILICA procedure. So although BASILICA was attempted, the precise control of the axis and traversal reduction could not be achieved, and the traversal wire repeatedly entered to left atrium. So this is a very big ascending aorta. So we managed to control the guiding word internally, but that was very difficult. So BASILICA was abandoned, and the TAVR SAVR was performed with subsequent chimney stenting in this case. So traversal is generally straightforward in normal anatomy. So however, in the presence of ascending aorta dilatation or horizontal aorta, maintaining proper control of the guiding system can be difficult. So substantially increasing the technical difficulty traversal like this. So is this where it should be? So at this point, we were not entirely confident that the laceration had been performed at the ideal site. So despite successful laceration of the left coronary leaflet, some tissue still appeared to remain in front of the coronary artery. So I was later confirmed, so inadequate result, but the case raised an important question. So are we truly lacerating the center of the leaflet rather than a more commissure or vasal portion? So this may be a key determinant of procedural success. So on the side view, our target is space between the two overlapping, so usually here, so the ring located on the left coronary artery sides. The fluoroscopic landmarks helps us identify the optimal traversal site and avoid laceration too close to the commissure site. So we usually use this emphasis view and the side view, so we can control which is the commissure side or the center of the leaflet or the base of the leaflet. So finally, what is this? So this is a tissue. So we can usually take out this like this tissue. But what is this? So this is a black one. So there are actually charred tissue, so probably created during traversal attempt, so like this. And this is a courtesy of Professor Norio Tada. So this is a lot of charred tissue like this. So we must use centering device during the TAVR SAVR procedure with VASILICA technique. So key to successful of VASILICA, so traversal is the most important part of the VASILICA procedure. Once successful traversal is achieved, the remaining steps are generally straightforward. To accomplish this, so obtaining the correct axis and the trajectory is critical. So it is also important to optimize the setup area rather than repeatedly adjusting a system later in the procedure. So ultimately, the choice of configuration of the guiding system play a key role in procedural success. Thank you very much for your kind attention.
Thank you so much. Our next lecture is Transcarotid TAVR Practical Tips and Tricks for Non-Transfemoral Access, to be given by Dr. Jin Kim of the Asan Medical Center.
I would like to thank the organizing committee for the opportunity to speak today. So in this talk, I will discuss transcarotid TAVR, focusing on practical tips and tricks. So here are my disclosure. So transfemoral access remains a standard approach for TAVR, and accounting for around 95% of all TAVR procedures. However, in some patients, transfemoral access is not feasible because of a peripheral arterial disease, severe calcification, or small and tortuous iliofemoral arteries. And for these patients, we need a safe alternative access route. So transcarotid approach has several practical advantages. The common carotid artery is usually spared from atherosclerotic disease, but surgical cut down is necessary. However, for cardiac surgeons, carotid exposure is a familiar procedure, and it provides direct and familiar surgical exposure, a relatively short access route, and a favorable trajectory to the aortic valve. So in this multicenter study, comparing transcarotid with intrathoracic access, transcarotid TAVR showed comparable mortality and stroke rates compared with transapical or transaortic access. It was also associated with lower rates of atrial fibrillation, major bleeding, and renal failure. And these findings support the role of transcarotid access as a less invasive extrathoracic alternative. So pre-procedural planning starts by confirming that transfemoral access is truly unsuitable. And this CT reconstruction is from the patient who underwent transcarotid TAVR yesterday at the live cases. And then we should evaluate the carotid anatomy on CT. So important factors include common carotid diameter, circumferential calcification, and plaque burden and tortuosity. So, but absolute contraindications for transcarotid TAVR are not fully standardized. However, we should avoid this approach when the common carotid artery is too small, severely tortuous, or has heavy calcification, plaque dissection, or aneurysm. And prior carotid endarterectomy is not an absolute contraindication. Also, routine circular Willis imaging is not required, according to recent consensus. Site selection should be anatomy-driven. So we should choose the site with adequate carotid diameter and less calcification or plaque, less tortuosity, and a favorable delivery angle to the aortic valve. And the left carotid is often preferred, but the right carotid is also acceptable if the anatomy is better. So we performed our first transcarotid TAVR in December 2023, and this image shows a neck incision from that first case. For carotid exposure, we make a 4 centimeter longitudinal incision parallel to the SCM muscle. And after exposure, at least 3 centimeter of circumferential dissection helps mobilize the carotid artery to provide enough room for proximal umbilical tape and distal clamping. The vagus nerve usually runs close to the carotid artery, so it should be carefully protected. And for sheath insertion, we make a clean transverse arteriotomy. So this allows a traumatic sheath insertion and facilitates flushing of potential debris before restoring cerebral flow. So cerebral protection is critical in transcarotid TAVR. So we use test clamping with bilateral cerebral oximetry to assess tolerance to carotid occlusion. And during the procedure, we maintain systolic blood pressure above 140 millimeter mercury to support collateral cerebral perfusion. And before restoring cerebral flow, we carefully de-air and flush the carotid artery. So one concern with the transcarotid approach is the potential risk of a stroke because the ipsilateral carotid artery is temporarily occluded during the procedure. However, transcarotid TAVR can be performed safely with careful selection and meticulous procedural techniques. So in this STS-ACC TBT registry, analysis of patients comparing transcarotid with transaxillary approach and treated with Evolut valves, mortality rate was comparable after propensity score matching, whereas the stroke rate was higher with transaxillary access. Because partially controlled carotid clamping and flushing, together with less interaction between the delivery system and the aortic arch, may explain this difference. So this slide summarizes our early and non-transfemoral TAVR experience. So in the earlier period, we have only performed the transapical or transaortic, but since 2023, we have exclusively performed the transcarotid TAVR, and as of yesterday, we have performed 12 transcarotid TAVR cases with no death or disabling strokes. So in summary, transcarotid TAVR should be considered a planned alternative rather than a bailout strategy. So it is best suited for patients with unsuitable transfemoral access and favorable carotid anatomy. Procedural success begins with CT-based planning and anatomy-driven site selection, and choose a safer carotid route, not simply the left or right. And finally, cerebral safety requires meticulous technique, including test clamping when appropriate, adequate blood pressure control, and careful de-airing and flushing before reperfusion. Thank you for your attention.
Thank you. Next speaker is Woo-Sung Kwon from Eunpyeong St. Mary Hospital of the Catholic University of Korea. He's going to talk about the management strategy of Evolut embolization.
Thank you for your kind introduction. Today, I'd like to share an Evolut valve embolization case and to discuss its management. The patient is an 88-year-old gentleman presented with chest pain and dyspnea with exertion. He had a medical history of diabetes, hypertension, and a permanent pacemaker insertion. His S-test score was 13. Echo demonstrated the mean pressure gradient was 45 millimeter mercury, and EF was 58%, and the severe aortic stenosis and the mild to moderate aortic regurgitation. On CT scan, the annulus area was 412 with a perimeter of the 73. Alveolus was slightly smaller, and the aortic valve total caching volume was only 134, which indicated minimal calcification. Based on this CT scan, we select the 29 millimeter Evolut valve corresponding to the 24% oversizing. This is the first valve deployment video. You can see the first half of the implantation with the around the 3 or 5 millimeter depths. This is the second half of the implantation. So we thought that the valve implanted appropriately. However, after only a few heartbeats, the valve migrated upward. You can see here with the contrast injection, clearly the valve moved up and migrated totally. This was likely related to the very low calcium burden resulting in the insufficient anchoring. So we need a second valve implantation. In order to prevent coronary obstruction during the second valve implantation, we decided to move the embolized balloon valve into the ascending aorta using lasso technique, snaring the THV. So we used the 25 millimeter gauge snare was introduced through the 6 French shuttle catheter, shuttle sheath, together with the 6 French JR catheter to capture the C-tap pattern. Although we made several attempts, we were unable to snare both C-tap. Since the capturing only one C-tap is generally sufficient to move up the valve, we proceed with the procedure after securing single C-tap and carefully pull back the valve into the ascending aorta. The next, we attempt to deliver 29 millimeter same Evolut valve. However, the delivery system could not easily cross the valve. You can see here, the snare was tightly engaged with the C-tap, creating the substantial tension. So at that point, we thought that the directly snaring valve frame could modify the device axis and facilitate the advancement of the second valve system, which called snare-assisted track technique. So using 20 millimeter snare and this technique, we were able to advance the second valve smoothly across the embolized balloon. We grabbed the second valve system with the snare, and then slightly pull back and modify the axis. And you can see the smoothly advanced the second valve into the sinus. The second valve was then implanted at a slightly deeper position and achieving a satisfactory result. So at that moment, we thought that the picture was a little bit awkward, but the case is over and everything is okay. However, another true disaster was waiting for us. After successful implantation of the second valve, the snare could not be retrieved. The problem was that the C-tap pattern had become trapped inside the tip of the shuttle sheath. Probably the shuttle sheath's inner diameter was equal to the C-tap thickness. It's like a kiloton chalk. So first, we attempt to pull back the shuttle sheath, but it didn't move. And the repeat push and pull maneuver of snare were also unsuccessful. And next, we advanced the coronary wire through the sheath and inflate the small balloon like a 1.0 or 2.5. Although the wire crossed easily and the balloon inflate itself was possible, we still could not separate the shuttle sheath from the trapped C-tap pattern. We also tested outside the body the dilatation capacity of the shuttle sheath tip with the non-compliant peripheral balloon. However, the tip of the shuttle sheath could not be expanded, so we didn't apply this strategy. So in summary, wire and the small balloon could be advanced, but the entrapped C-tap remained completely immobile. So at the point, it was very frustrated, and we felt that there were no further bailout viable option. So we immediately contact our cardiac surgeons and ask them to stand by in case emergency surgery became necessary. The next strategy, actually the final strategy for us, was sequentially upsizing of the inner catheter to maximize support and attempt the separation of the trapped pedal. It's like a counterclock force. So we used the inner catheter stepwise, like rigidity and pushability. The 5 French JR and 6 French shuttle dilator, 6 French JR for guiding catheter, and the 6 French schistless guiding catheter with the inner dilator, introducer, U-cath. So after several attempts, pedal was finally released. However, the shuttle sheath itself had not actually disengaged from the pedal. Instead, you can see here, the distal tip of the shuttle had detached from the main body of the sheath. On the fluoroscopy, the detached shuttle sheath was seen move up and down with the broad flower while remaining attached to the sheath pedal. Fortunately, during this procedure, the patient's hemodynamic status was stable, so we decided to finish this procedure without further intervention. The next day, the formal echocardiography showed a very nice result with the mean pressure gradient is only 9 millimeter mercury with no significant abnormality around the aorta and the valve. So far, the patient has been doing well. On a recent X-ray examination, the detached shuttle tip can still be seen here and attached to the valve. So let me summarize the case. Valve embolization may occur during the TAVR with the SEV, snaring and elevating the embolized valve while advancing the second valve, which called the lasso technique, is commonly used bailout technique. When the second TAVR system cannot cross, snare-assisted tracking technique may facilitate the device advancement. However, CT pattern entrapment within the snare sheath rarely but can occur because further manipulation can cause valve embolization, aortic injury and dissection, or hemodynamic instability. Early heart team communication and immediate surgical backup is essential. Thank you for your attention.
So I think this is the last talk, and it's the cutting-edge SAVR in 2026, totally endoscopic surgery, to be given by Jae Suk Yoo from the Asan Medical Center.
Thank you, Chairman. Good afternoon, ladies and gentlemen. My name is Jae Suk Yoo. It's my great honor to have this opportunity to share my experience in front of you today. I have no disclosure regarding this issue. As most of the attendees here are cardiologists, let me briefly define minimal invasive cardiac surgery. As you can see, minimal invasive cardiac surgery avoids sternotomy, instead utilizing a small mini thoracotomy or mini sternotomy incision. And this is a TAVR era, so many cardiologists and cardiac surgeons thinking about the future cardiac surgery will be toward this minimal invasive approach. And then what then is totally endoscopic approach? If you watch this video, you will understand what totally endoscopic approach means. The advantages of totally endoscopic approach are clear. Comparing these two video clips performing similar procedures, as you can see here, the totally endoscopic approach provides a brighter and magnified view, and with 3D totally endoscopic approach, you can get the depth perception and tactile feedback. This shows my journey in minimal invasive cardiac surgery. I started my independent surgical career in 2014 after completing my fellowship at at Asan Medical Center, and mentored by Professor Jae Lee, a pioneer of minimally invasive cardiac surgery in Korea. I used that experience to start direct vision minimally invasive cardiac surgery. This is a direct vision mini thoracotomy incision. It's the entry-level stage of minimally invasive cardiac surgery. And in my effort to move forward to the next level, I initiated the Da Vinci robotic program. This was my first case of robotic mitral valve repair. But I encountered several problems. The biggest issue was that the absolute necessity of a highly skilled bedside surgeon like Dr. Nali Waifong, but in reality, it was impossible for me to have this kind of dedicated bedside cardiac surgeon. And additionally, the lack of tactile feedback was a significant limitation. And furthermore, this additional port incisions required for robotic arms was another challenge for me. It required more sites for bleeding control, which is quite demanding for the bedside surgeon. So it was around the time I came across the 3D totally endoscopic approach by Professor Toshiaki Ito. And I was deeply inspired by his work, and I adopted these procedures to my procedure. This is my routine setup for 3D totally endoscopic minimally invasive cardiac surgery. The main incision is 3 to 4 cm incision, and this is the postoperative wound. And this is the routine setup. I conduct all my cases with just only one surgical assistant. This is also an excellent solution for human resource efficiency in cardiac surgery. And as for the aortic valve replacement, previously I mainly performed right anterior mini thoracotomy, direct vision AVR. But from 2019, I gradually transitioned into a totally endoscopic AVR. In terms of the level of difficulty, I consider totally endoscopic AVR is the most challenging stage. You can compare these two videos. This shows the direct vision right anterior mini thoracotomy approach AVR, and this shows the totally endoscopic AVR. It's a clear and magnified view. But the surgical wound, if you compare just the cosmetic and just the incision size-wise standpoint, some people might ask, why do we need totally endoscopic AVR? However, I strongly believe that the true essence of the totally endoscopic AVR is not just about the size of the wound. I think it's about its versatility and its expandability to other complex cardiac surgeries. So I believe that once a cardiac surgeon feels comfortable with totally endoscopic AVR, it serves as a gateway to performing other complex concomitant procedures. And this patient had a history of Ross operation resulting in very severe peri-aortic adhesion. But as you can see, the 3D scope allows us to visualize even deep corners, and it offers the tactile feedback. So the combination of this high-resolution imaging and tactile feedback is a crucial factor in versatility of 3D totally endoscopic cardiac surgery. So I think as long as the 3D scope can reach, the complex anatomy is no longer a significant surgical barrier. And that's how, since 2024, I've been applying 3D totally endoscopic cardiac surgery to multi-valve cases. So I'd like to show you some video cases. This patient had a severe AS with basal septal hypertrophy. As everybody knows, these days, the post-TAVR suicide left suicide left ventricle is another very important issue. When I attend some interventionist conference, there were hot debates regarding this problem, like alcohol ablation or lifelong mevakamten use or RV pacing, or something like that. This patient, I decided to perform totally endoscopic AVR with septal myectomy. The routine totally endoscopic AVR approach, and after aortotomy and the aortic valve leaflet removal and debridement is performed. And after removing the leaflet and annular debridement, you can see this basilar septum directly. It offers straight access to the basilar septum, unlike right anterior direct vision mini thoracotomy. In RAT approach, the septal myectomy, combining septal myectomy is a bit tricky, but by the endoscopic vision, you can perform basilar septal myectomy. This is not so tricky. So after completing the septal myectomy and the valve suture was completed, and then aortic valve replacement was performed. And this shows the postoperative basilar septum. And this is another case. Using 3D totally endoscopic approach, we can perform TAVR explantation minimally invasively. This is a world first case of TAVR, totally endoscopic TAVR explantation. And many interventionists debate regarding the issue, BASILICA, unicorn technique, very complex technique, but I think we can do this TAVR explantation with not so difficult, not very difficult, so just core surgeons for this kind of TAVR explantation when it's required. Using 3D totally endoscopic approach, the meticulous separation of the prosthetic valve, and it can be performed safely, and after TAVR explantation, the AVR is quite easy. And also in multi-valve surgery, it can be performed by 3D totally endoscopic approach. So from 2017 to 2026, I performed 769 cases. Most of the cases were mitral valve, but it's expanding the indications, including AVR and other complex valve surgeries. So to summarize, 3D totally endoscopic cardiac surgery is no longer limited to simple single valve procedures. Its superior visualization combined with direct tactile feedback provides the versatility required to safely navigate complex multi-valve disease, hostile chest anatomies, and high-risk clinical scenarios. The boundaries have indeed been pushed. The future of complex cardiac surgery lies in the endoscopic domain. Thank you for your attention.
Thank you. We have about 5-10 minutes, so should we just have a little bit of discussion?
Yep. 10 minutes.
Yep.
So now we have distinguished 6 panelists from Thailand, Taiwan, and Korea. So the discussion is open to the panelists and to the floor.
Yeah, I have one question to Dr. Hachinohe. Yeah, so you showed us very interesting cases using the BASILICA technique. Is there any way to confirm whether the BASILICA procedure, the cutting of the leaflets, modification of the leaflet was appropriate or not? So is there any way to visualize the result of the BASILICA procedure, like a TE or
Yes, thank you very much. We usually check using TE and fluoroscopy. So just, but we can't precisely by TE image. So that is a main problem, Basilica technique.
So do you know that with the the jet flow or the direction of jet flow or?
No, we can't check the
Okay.
exact position.
May I ask a question to Dr. Jin Kim and the DW Park together? So maybe a very silly question. So first of all, congratulations on your very successful 12 cases of transcarotid TAVR. But why do you open the carotid? Why don't you do like a femoral artery? Is there any differences between carotid and so you can make use of sono and the
Percutaneous mean,
yeah, device closure and other things. So then, if you can do that, you don't need Hojin. You can by yourself without cardiac surgeons. Why do you do that?
Yeah, the yesterday case is both femoral artery is quite narrow. Is at least lumen diameter for transfemoral should be more than 5.0. Yesterday case is 2.2 in both artery. In the femoral access is totally is not feasible. The reason why we do transcarotid.
So you can do it percutaneously without opening the carotid, without surgeon. Why do you open with the surgeon's collaboration?
I mean, do the transcarotid TAVR percutaneously, like using Proglide or stuff like that. And after you pull out the sheath, I guess if there is some bleeding or some disaster happens, there might be a catastrophic because it goes to the brain. So that's why you need a surgeon. You need a surgeon who can have a clear access and just close very without any complications.
But as Dr. Shimamura excellently showed, we can manually compress the ruptured ends safely in the beating heart.
Hojin will allow me, and the next time I try to.
I have a question to Jin Kim. Yeah, so you showed us your technique. And I wonder whether it is necessary to occlude the proximal carotid artery during the procedure. And you said you don't even need to check the patency of circle of Willis. So really, I mean, there is an increased risk of reduced flow to the brain. So I don't quite understand. Yeah.
I 100% agree, actually. And in the slide, I just referred from the recent consensus document. But actually, in our institution, we almost always evaluate the circular Willis with the brain MRI. And I think it's safer to do this. And if there is any problems there, probably I would do the test clamp just more meticulously or just ask the anesthesiologist to increase the blood flow just way above like 140, 150.
Yeah, Dr. Jin Kim, I have a question. In your slide, you show the horizontal arteriotomy in carotid artery. What is the horizontal arteriotomy benefit?
You mean transverse arteriotomy?
Yeah.
So all I do is expose the carotid artery and just open the carotid artery to introduce a sheath atraumatically. So, I mean, transverse arteriotomy is the best option. I do not do the longitudinal incision along the carotid artery.
I think looking at, when you sort of cut down to the carotid versus cut down to the femoral artery, a femoral artery cut down usually because there's disease, and therefore it's actually quite difficult because sometimes you have an arterectomy and so forth. The carotid, generally, you pick that because there's not much disease to go with and very shallow, right? So I think for most of the surgeons can get to the carotid and have it sort of looped pretty quickly. So I think that's actually, and again, control is a big issue. If you start bleeding, you have no contralateral going back in to block that and anything like that. So I think cut down is the way to go. I have a question for Dr. Yoo about the cardiac surgery. So all your endoscopic, totally endoscopic cardiac surgery are all with peripheral bypass, I presume, not central bypass. Is that correct?
Yeah, for sure. It's almost in every cases. I always do the peripheral cannulation.
Sorry.
This is small incision. You cannot do central cannulation.
Right. So is there risk in peripheral bypass surgery? I mean, peripheral bypass because, obviously retrograde perfusion as well as people who have, peripheral vascular disease and visualization of the arteries and so forth. So you think central versus peripheral, do you screen them? Meaning if there's issue with the peripheral arteries, you actually don't do the total endoscopic surgery?
Yes, thank you for the good question. We always check the preoperative CT angiogram, the whole CT angiogram. If the patient's peripheral aorta, abdominal descending aorta is hostile, the second option is the axillary cannulation. So I don't think it's problematic.
And you do the peripheral access using TE guidance through the wire, you don't do fluoroscopic?
TE guidance, guide wire insertion.
Okay, thank you.
Hello. So maybe I'll comment on the first topic. We haven't talked about it. In terms of annular rupture, I think Dr. Shimamura pointed out that it's not always annular rupture, but SOV rupture, and we always focus on sizing at the annulus. I wonder if you have any model of how to prevent SOV rupture in terms of, for example, device to SOV size and calcium ratio and stuff?
Yeah, so we always have to check the size of the sinus of Valsalva and see the burden of the calcification. And recently we have a research that we excise the calcification nodule and make a compression to see how stiff the calcification is. And by comparing to the preoperative CT, we have our dedicated software which can predict the hardness of the calcification. So the combination of this kind of software will help you to estimate how the calcification is, not only the mass of the calcification, but how hard it is. So I would like to introduce this software in maybe the next year.
I have a question for you. Would you like to consider place a balloon expandable valve to seal the annular rupture? It may save your time. Yeah, using the skirt to seal the annular rupture.
I have heard that about that technique, but I'm actually not sure about the how it works. And usually, this kind of patient has a very small, tiny aortic root, so the risk of coronary obstruction exists when you do the volume valve in such a small annulus. So if there is no risk for coronary obstruction, I would maybe that it's a good option.
I would like to share my experience with transcarotid approach. I have more than 15 cases of transcarotid TAVR, and I use so-called double sheath technique to prevent the occurrence of stroke. And my patient with transcarotid TAVR, the instance of stroke or TIA is 0. The double sheath technique is that when we place 18 French sheaths into ascending aorta, we also place 7 French sheaths in the opposite direction into the same carotid artery. Then we shunting the blood from ascending aorta to the carotid artery. So from our lab study, it can provide about 70% of cerebral circulation to the carotid artery, so that it may reduce the occurrence of stroke or TIA after transcarotid TAVR.
Thank you, Dr. Chandavimol, for your insightful tips and experience, sharing your experiences. But now time is up to wrap up this session. And I appreciate Dr. Yang and speakers and panelists, as well as audience, for valuable talks as well as discussions. Thank you very much.